We are live now, Doctor. Sorry.
Yeah. Good evening, everyone. So welcome to this IJO-YOSI live wire episode 6. So we are having this capsule for the last, a year or so, along with the guidance and support of Dr. Vanati ma'am, and welcome you all to this another very enlightening and very enriching event on conducting an RCT, survey designs, and letter to editor. So before we begin, the YOSI Journal Club, Publish or Perish, a call to action was one of the brainchilds of Dr. Sonal Kalia ma'am, and then it was being organized by Dr. Nupur and also by Dr. Anujit for the previous year. And now the new team run by Dr. Divakant sir, our president, and the dynamic governing council along with him, followed by 20 executives whom you will be seeing here with us for this particular episode as well. So the concept of YOSI Journal Club, learn and grow. So we try to connect with YOs, fellows, PGs, first year, second year, and third year, to make sure that it is covered in a holistic way so that we don't miss out on any important aspects of the journal club facets that a young ophthalmologist needs. And the journal club assessing research literature, these are some of the concepts or topics that we focused on. And the format of the journal club was, we had a MAARIE format with a moderator, panelist, research expert, mentor, and then the methodology, assignment, assessment, results, interpretation, and extrapolation in a step-by-step manner was followed. And this is our new team, and also we are added by Dr. Ayushi and Dr. Pranesh as well for this particular episode. And if you are a YOSI member and you want to be a participant of the YOSI Journal Club activity, either scan this QR code, or you can either ping us to this WhatsApp, or you can send a mail to the below yosi.journalclub@gmail.com. So it's all inclusive, and you can be as a participant in the next month Journal Club as well. And these are some of the activities which we take fond in sharing. Our unique activities which started in 2021. We had 4 activities in 2021, and you can see that it escalated to 5 activities starting from all subspecialties in 2022. And then we had close to 7 activities of subspecialties in 2023, where we had the first episode with IJO Live Wire with Vanati ma'am support and the YOSI Governing Council support, where we had on biostatistics. And here we are for the year 2024, where we have had 4 different subspecialties from January to December: refractive, retina, orbit, and glaucoma, along with 3 previous capsules of IJO Live Wire from case reports, photo essay, original article, and managing plagiarism or avoiding it, and publishing, writing, and beyond, how to approach rejections, which was the last episode that happened in October. And today we are here joined by our chief guest Vanati ma'am, as well as our YOSI president. I can see Dr. Divakant sir here. So before we start, a few words from Dr. Divakant sir before I introduce all the speakers and the moderators of the day. Over to you, sir.
Thank you so much, Prasanna. And I think I would like to take this opportunity to thank Dr. Prasanna for all the efforts he has been putting in, and of course the whole team. So under his leadership, the IJO Live Wire and the YOSI Journal Club is doing an excellent work. And thanks to the star speakers today, Dr. Sagnik, Dr. Akshay, and Dr. Surbhi. Some very interesting topics to be discovered, so to be discussed. Look forward to the good discussion. Over to you, Dr. Prasanna. Yeah.
Thank you, Divakant sir, for all the support and all the inspiration and guidance throughout this tenure. And likewise, the YOSI Journal Club, we have few other initiatives as well, which Ayushi will be sharing regarding the survey as well. Thank you, sir, for keeping us engaged and for all the guidance and support. Thank you, sir. So without much delay, so Vanati ma'am will be joining us shortly. So she told us to proceed with this event. So I'm Dr. Prasanna Venkatesh. We have Dr. Ayushi Agarwal, who's our executive member. followed by our YOSI conveners, Dr. Niranjan and Anujit, who are also part of, Niranjan is part of the current executive team, and Anujit was one of the brain behind the previous journal club issue, which he did along with this team in the last term. And we also have another dynamic, Dr. Pranesh Ravi, as well as Dr. Arshi, who's part of the executive team as well, joined by our speakers. So we'll have the introduction of the speakers. Before that, a quick update from Dr. Aishi on behalf of the Journal Club team. Aishi, you are ready to screen share?
Yes,
Yeah, so
can you
we-
unshare your screen?
Yeah, I'm going to do that. So we at Journal Club, we have devised a survey under the brains of Dr. Aishi Agrawal. It's her idea where she has brought out important facets that a young ophthalmologist would need. So we wanted to understand what a YO would need so that we can have a Journal Club curriculum, something that Aishi as well as myself along with the whole Journal Club team, we discussed, and we have brought out very important, pertinent questions, which is very important for a YO. So we would request you all to kindly help us, to help you with this survey. We will be able to make the work more relatable to you so that we will be able to guide you better. So over to you, Aishi, to share a few words on this survey before we start the event.
Thank you, sir. I just wanted to add that it's completely anonymous and it takes less than 3 minutes of your time. It is exclusively designed for trainees. So if you're not a trainee, then it would be great if you can amongst your trainees and co-fellows and co-residents. And if you are one, then please fill it because it will be open only for 10 more days. After that, we'll close the response. It will help, as Prasanna sir said, standardize the journal clubs as a part of the curriculum. So please share and spread the word.
Thank you, Aishi. Can you stop sharing? Yeah. With that, I would like to call upon Dr. Arshi, one of our conveners for today, to call upon CV of Vanati ma'am. Arshi, over to you. Arshi, you are there? Anujit, over to
Yes.
you to invite madam.
Yes, of course. Thank you so much, Prasanna, sir. And it gives me great pleasure to be inviting the chief guest for this evening, none other than Dr. Vanati Madam, who is a professor of ophthalmology of cornea lens and refractive services at the RP Center, AIMS, as well as the current editor of the Indian Journal of Ophthalmology. She has also been nominated as a council member of the Afro-Asian Council of Ophthalmology. Dr. Vanati Madam graduated from medical school from the prestigious Madras Medical College and then following with her post-graduation and super specialization from AIMS New Delhi and an international clinical fellowship from the Singapore National Eye Center, serving as faculty, professor, senior eye surgeon at AIMS since 2005. She is the first woman editor of the Indian Journal of Ophthalmology. She has a vast amount of clinical experience related to cornea, cataract, and refractive in medical as well as surgical. She's also known around as a compassionate teacher, a researcher, and been a mentor and a guide to not only her students in AIMS, but as well as the entire country. And it goes without saying, she has numerous academic accolades, and I will just go through a few of them, which is including but not limited to greater than 250 publications and 80 book chapters in national and international books. She's also the author of postgraduate ophthalmology and undergraduate ophthalmology, and is the winner of the AIMS Research Excellence Award, several Best of IJO, IJO Silver, and Appreciation Awards. With that, I would like to welcome ma'am.
Thank you. Thank you, Anujit, for the warm welcome to ma'am. Next, I would like to call upon Dr. Niranjan, one of our, again, dynamic team members, to welcome the first speaker of the day, Dr. Sagnixon.
Thank you, Prasanna sir. Again, at the outset, I would like to thank UC Governing Council, IJO, and Prasanna sir for having me part of this team, wonderful team. And it's indeed my pleasure and honor to welcome our first speaker for today's evening, Dr. Sagnik Sen. So Dr. Sagnik Sen is a retinal surgeon at St. Thomas Hospital in London, who specializes in retinal detachments, vascular diseases, and preventive ophthalmology. So he's completed his training in ophthalmology at the prestigious AIMS in New Delhi and a clinical research fellowship in retina and vitreous surgery at Arvind Eye Hospital, Madurai. So he's covered all the way from north to south, all over India. And he also completed a fellowship in medical retina, genetics, and uveitis at Moorfields Eye Hospital in London, which is the oldest in the entire world. And to add to his research accolades, Dr. Sen is involved in clinical and translational research and has published work in medical journals, books, and atlases. He's a research fellow at Moorfields and also has several areas of interest, which is his passion as well, about preventive care, artificial intelligence, predictive biomarkers of eye diseases, and many more. He's also an advocate for awareness of diabetic retinopathy and myopia. It is indeed our privilege to have you with us today evening, sir. Over to you.
Agnik, over to you for
Hi
your
there. Thank you. Thank you for the kind introduction. Thanks to IJO-YOSI team for this wonderful organization of this event. I'll quickly share my screen. 1 second. Can you see my screen?
Yes.
Okay. All right. So the topic for today is conducting a randomized control trial, RCT. So what is an RCT? An RCT is a study design where participants are randomly assigned to receive one of several clinical interventions. And the purpose of an RCT is to evaluate the effectiveness and safety of interventions, mostly new interventions before they are launched for the public. And key feature of an RCT is randomization, which eliminates selection bias. Other kinds of studies which can prove efficacy are case control studies and cohort studies, but RCT comes on top of all of them. So why do we need to conduct RCTs? Because RCTs are gold standard for establishing causality, reduces any kind of selection bias or observer bias, and also produces high quality of evidence. So before systematic review or meta-analysis came through, RCTs were the highest level of evidence. Now we know that meta-analysis can summarize results of RCTs and is considered the highest form of evidence. The composition of a trials unit has many people. So the most important person in a trials unit is the principal investigator who leads the trial and ensures scientific rigor. And he is the one who oversees development of the research protocol. Then we have the administration side, which involves trial managers or coordinators, data management team. Data analysis team involves statisticians, clinical research associates, and regulatory and ethics team who take care of informed consent. They handle the audits and inspection of the trial. Investigators and clinical staff are the research faculties or the research fellows who are involved with conducting the trial at different research sites, because it might be a multi-centric trial as well. And they are the ones who screen and recruit the participants and collect data. We also have quality assurance team, administrative support team. And one very interesting part is patient and public involvement specialists. So PPI is very important. PPIs basically do a survey among the normal patients and publics, among patients and normal public, to try and understand what are their requirements, what is their say in conducting the trial, whether they want to edit the protocol in some way or not. Now, we also have a data and safety monitoring committee, which involves groups of individuals with varying expertise. So they can involve statisticians, clinicians, and clinical trial specialists who are independent of the study, and they are responsible for ensuring safety of participants by monitoring the study performance. So they can make recommendations regarding early termination of the study or continuation of the study based on any significant adverse event which has been reported, or there is no likelihood of finding any difference. Now, core elements of an RCT are finding a research question, involves randomization, and finding a control group. Now, blinding is very important for RCTs. And finally comes the outcome measures. Step 1 of an RCT is planning and design. So this involves defining the research objectives and hypotheses, determine the inclusion-exclusion criteria, select the sample size, and develop the protocol. Step 2 involves methods. So the randomization may involve simple randomization, stratified randomization, or block randomization. And this ensures that the groups are comparable. Step 3 involves intervention and control group. So intervention group or the experimental group receives the intervention, the treatment or surgery. And control group is the group which receives either a placebo or sham or a gold standard treatment. Depends whether the trial is a placebo controlled trial or evaluating effectiveness or safety over a well-established standard form of treatment. Blinding is step 4, which involves either single blind, where only the research participant, the patient, is unaware of the randomization. Double blind means the investigator also doesn't know who gets the treatment. And triple blind means the analyzer or the data analyst, they are also not aware who gets the treatment, who gets the sham or the gold standard. And this is very important for reducing bias. Step 5 is collecting the data. So this is done by research fellows or research clinical trial fellows who document the baseline measurements, follow-up and monitoring, and use standardized data collection tools like REDCap, etc. Now, before data analysis is done, one very important step is to encode the data. So that is basically for blinding. So that data has to be transferred from the research site to the centralized data center. And then the data analysis is done by the statistician team. Intention to treat analysis is very important for RCT. And statistical tests are done for group comparisons and also adjusting for confounders, which may affect the results like age, sex, etc. Final step is reporting and dissemination. So always follow the consort guidelines, and the data can be published in peer-reviewed journals, and also the results can be shared with different stakeholders if there's pharmaceuticals involved or funding involved, etc. Now, ethical principles of RCT are autonomy, beneficence, non-maleficence, justice, equipoise, transparency, and accountability. So all of these ethical principles ensure that patients get maximum benefits from the RCT, harm is avoided, and the treatment is just, so fair distribution between the the study group and the control group. And obviously there are challenges in conducting RCTs. So there can be recruitment issues, there can be ethical dilemmas, and strict adherence to protocols need to be ensured. Finally, we do have dropouts from trials, so the final number might be different, which is why we need to have intention to treat analysis. Just to summarize, starting from planning and preparation, then trial design, and then the trial needs to be registered. In India, the registration is done under CTRI, and also an ethical clearance need to be taken from the Institutional Review Board or Ethics Committee. And then we go on to recruitment, randomization, finally, intervention, administration, data collection, then monitoring and safety, where the interim analysis is performed, then data analysis and reporting and dissemination is the final step. So we know of multiple landmark clinical trials in ophthalmology, starting from herpetic eye disease study, ARID study, then ETDRS, DRS, which have given us brilliant results. And most of our treatment guidelines and treatment standards are based on all of these landmark clinical trials. And we keep conducting many clinical trials. In India also, we have started doing many RCTs. Professor Namrata has been involved in so many landmark publications in IJO. So yes, we definitely can do RCTs in India as well, but the ethics side, definitely we need to be very careful, because I think the organizations are getting quite strict with ethical principles, and in future that is going to be very important that each and every clinical trial is registered properly. The journals also look for proper CTRI registration, or you can register your trials in US as well. But yes, that's all very important. And thank you for inviting me for the talk today. You can drop me an email if you're interested to know more. Thank you.
Thank you, Dr. Sagnik-Sen, for this enlightening capsule talk. Arshi, you had a question to ask, Dr. Arshi Singh. Difference between justice and equipoise.
Justice and equipoise, please. Yeah.
Yeah.
How does it relate to the treatment terms?
Sagnik, you have a question from Dr. Arshi. The difference between justice and equipoise.
Yeah, just a minute. So I think justice and equipoise, they are used for maximizing the benefit. So that both the arms are getting the benefits of the study, and you're not stopping anybody from getting the benefits of the treatment. And if there's any uncertainty so equipoise takes care of the uncertainty, which means if you're unsure that the drug is not going to benefit, then you would probably not be selecting that treatment. So you select only treatments which you know have proven efficacy. And if you think that the drug is not going to help, then you cannot select that drug. Can you see that?
Any other question from any of our panel members or our hot seat participants? Dr. Samir, anything that you want to ask?
Hi, good evening, sir.
Yeah.
So, I had a question. For example, if you are evaluating a treatment against a gold standard, so for a group, you are actually depriving them of the gold standard treatment. So, is that ethically like, is it going to cause any problem, or is it ethically correct to do that? So you're muted, sir.
Yeah, sorry. Thank you for the questions. I mean, very good. So I think this is very important for cancer treatments because you cannot withhold treatment for them. So
You're on mute.
Again.
You're on mute, Dr. Sagni.
oh, sorry. Yeah, so for cancer trials especially, you cannot withhold treatment from patients. So it has to be drug A versus drug B. And that is where equipoise justice comes in, where you have to prove that the drug A, which is being evaluated, is actually either equivalent or better. So that has to go through the ethics committee, which is why a lot of RCT proposals get rejected, because you cannot convince people that they are probably at the same level. But yes, you cannot withhold treatment. But for treatment, for diseases like CSCR, for example, where observation is one of the proven treatment arms, and if you're evaluating, say, PDT versus observation, that makes sense. So it has to be disease specific. You cannot go to all diseases and design sham control trials. If if you're evaluating anti-VEGFs for say CNVMs, you cannot not treat them. So you have to treat them. But if you have a different drug, you can give that different drug and compare against Eylea or Vabysmo or whatever your standard treatment is.
Thank you. Thank you.
Sagnik, you have thank you ma'am, for the question. Sagnik, you have another question from Dr. Ashwin PR. What is the difference between superiority to non-inferiority trials? Ashwin, you want to ask it to Dr. Sagnik directly also?
Yeah, like the basic question being what is superiority trial and what is a non-inferiority trial? It's a little confusing sometimes. We can just clear it up. Am I audible?
Yeah, you are audible. Sagnik, can you hear his question?
Hi, yeah, sorry. I think over the top of my brain right now, I can't recollect, but mostly as far as I remember, non-inferiority trial. So any trial question, when you design a null hypothesis, you mostly design for a non-inferiority. That's, I mean, standard is you always prove that your drug A is non-inferior to drug B. By definition, statistically, you cannot say that one drug is superior to the other, because your null hypothesis is never drug A is better than drug B. The null hypothesis is always drug A is non-inferior to drug B. But a lot of trials, if you look at a lot of retina trials which have compared Lucentis versus Eylea versus Avastin, they've actually gone and said that Eylea and Lucentis are comparable, whereas Avastin is not non-inferior, which doesn't make sense. So there's a lot of pharmaceutical and industry push in those kind of languages, which I think we should tread very carefully. But mostly trials are designed to be non-inferior. But don't take my word for that superiority part. I have to check.
Thank you, Dr. Sagnik.
Prasanna, sir, do you mind if I add something?
Yeah, please, Dr. Ashwin.
So usually the sample size calculation is different for both of these trials, and a non-inferiority means that usually both treatments are equally effective, but one treatment might have less side effects or might have some advantage over the other, but not in terms of efficacy. However, a superiority trial is set out to prove that the newer treatment or whatever treatment you're prescribing is better than the previous gold standard. I remember that someone in a statistics class had said that the sample size calculation is different. Plus, most of the trials that we conduct are non-inferiority rather than superiority. And Baki, the
Right,
experts
thanks.
will
So
let us know.
yeah, I think something like this. So you predetermine that you want to establish that there is a difference of results or something like that. Yes, you're right, Arshia. Like you decide a question and then prove it, something like that. But the null hypothesis is still that they're not different. So you disprove your null hypothesis.
Thank you, Dr. Sagnik. If we don't have any more questions, I think we'll move to the next speaker of the day. So I would like to call upon Dr. Arshi to introduce the next speaker. So our next speaker is going to be none other than Dr. Akshay Nair, sir. Arshi, over to you for introducing sir.
It is my absolute honor and pleasure to introduce our next speaker.
1 second. 1 second.
Yes, Dr. Akshay Nair, sir. Sir has completed his Diplomate of National Board DNB Ophthalmology from Shankar Nethralaya, Chennai, and then went on to do a fellowship in oculoplastic surgery and surgical oncology from LV Prasad Eye Institute, and thereafter in 2015 from Mount Sinai Hospital in USA. He has more than 140 published peer-reviewed articles, more than 20 chapters, and is a reviewer for more than 40 journals. He has multiple awards and honors to his name, amongst which are the AIOS Best Paper Award in Neuro-Ophthalmology and Ocular Oncology, the AAO Best Poster Award, the OPAI Best Paper Award, and also the YOSI Young Ophthalmologist Award. He has held various positions in the Oculoplastics Associations of India, in YOSI, and has been an active member of the Asia Pacific Society of Ophthalmic Plastic Reconstructive Surgery, and also is a member of APS, OPRS, and AO1 network. Thank you, sir, for being here. We're looking forward to your talk.
Thank you, Arshi, for the kind introduction to Akshay sir. Akshay sir has sent a video, and he'll be available to answer the questions after the video has been played. So just let me know if there is any glitch in the video when I'm trying to play it, from my side. And here it is, the video.
Good evening. I'd like to thank YOSI for this invitation to come and speak on this platform, especially Dr. Prasanna and Dr. Ayushi for the invitation. I'm speaking on survey designs, the what, why, and how of them. Why do we end up conducting these surveys amongst ophthalmologists? We often see in different WhatsApp groups that there's someone posting about an invitation for a survey. Well, surveys are important because they really give us insights into what the real world trends in management of diseases are. What is the epidemiology of diseases that are being seen by patients out by the surgeons and doctors in the real world. It aims to identify the quality of training that is happening, to identify gaps in knowledge and whether there is a particular skill set that people are lacking, and essentially to know the state of practice and to know the state of the practitioners is why we do surveys. For example, I think going back 5 years ago, in March 2020, when there were rumors about a lockdown, and finally on 22nd March, we had the Janta curfew where we were all sitting in our balconies, banging plates and clapping. And finally, on 23rd, we had the lockdown, and we didn't know what to do as ophthalmologists. This was unprecedented. We kept our hospitals and clinics closed, and we were wondering, am I the only one keeping it closed? Should I be operating? What precautions should be doing? And on the day of the lockdown, we actually came together, three of us, came up with this survey, sent it out to a lot of people, we took their responses, and this is what got published immediately in April of 2020. And this is through this survey, we came to know that most of us were actually not seeing patients. There was a near total cessation of all elective surgeries. Only 27% of ophthalmologists were actually seeing emergencies. And there was clear uncertainty about how and when to resume surgeries. And there was a need for, the bodies like AIOS to come up with guidelines. So the power of this survey was that it was very reassuring because, it let people know that they're not alone and everybody's in the same boat. So I'm going to go ahead and give these 10 pearls on how we need to polish or, sharpen our surveys that we conduct. First is the clarity of the idea. We need to have a well-defined focused topic. We cannot choose a very broad topic like, for example, we look at training opportunities among residents in India. Well, if we do that, then we need to focus on every subspecialty, cataract, glaucoma, retina, squint, oculoplastics. But instead, the most common surgery that residents do is cataract surgery. So we should focus mostly on cataract, and maybe a few questions on other specialties. Remember, our length of the survey is extremely important, apart from not just the clarity of the idea. Fatigue or annoyance sets in when the respondent has to answer too many questions. And over the years, I've realized that about 12 to 15 questions or multiple choice questions is probably the limit where you can have the respondent's patience. Beyond that, they lose patience and they just give up midway. And before going out and embarking on the actual project of conducting the survey, it's important to ask whether you're presenting new data. If you're going to ask questions about the same topic over and over again, people or respondents tend not to respond to it. So make sure you're presenting new information, or at least you're clear about what you're doing. And which brings me to my next, which is with your invite to participate in the survey, you should always have a brief introduction. And in this introduction, you talk about who is this survey for, what is this about, why are you doing it, and who is the survey being sent to you from, and how long does it take for the survey to be completed. If you complete these things in that single message, you get all the information that is needed. And if you're sending it out personally to someone on say, social media like WhatsApp, always add a small personal touch like, hey, feel free to reach out in case you have any doubts. Because people often come back and ask me, hey, can I be a co-author if I respond to this survey? As a rule, just by responding to a survey, you do not get co-authorship rights. So, you need to be clear about these things. You see this message as a screenshot. Hey, this is a survey for oculoplastic surgery. So it explains for whom. It aims to collect information on lacrimal surgery. Okay, what? Why? Because it's the COVID-19 pandemic and we want to know what precautions you're taking. How long does it take? 5 minutes. Please take the survey, you add the link, and also the names of the people who are sending it. So, be very clear and honest about what it is. And also, you can also add the reason as to what you're going to do with the data and things like that. Also, if it is an anonymized survey, you need to mention that this is going to be an anonymous survey because anonymity is extremely important. Anonymous surveys are those where there is no identifiable information taken. The person who's taking the survey doesn't have to put in their name, their email address, or their institute, or any identifiable information. Or most of us use Google Forms, and in Google Forms, sometimes a sign-in is mandatory, and we don't realize because that's the default setting. So we need to go in and switch that off and let people know that, hey, you don't need to sign in to take my survey. Many times people come in and if they're redirected to a Google sign-in, they simply switch off and don't complete the survey. So if you really don't need identifiable information, you don't need to get it as well. It's important because people who give information about things like adverse events or complications only under the protection of anonymity. At the same time, patients tend to exaggerate, respondents tend to exaggerate. Like if you're being asked how many intravitreal or how many cataract surgeries do you do, and the survey is being taken by a resident who's actually not doing any, they may just end up writing 1,000 just to be irrelevant. It doesn't happen frequently, but it can. But which is why, because that is so rare, I'd rather prefer anonymity over compulsorily having to sign in, because that way you get more genuine response, like this survey where we asked the residents about their cataract surgical training status. Now look at this, 34.6% of the respondents said that they get no independent cataract surgeries through our residency. Do you think you would have got that much response had we asked them to identify themselves with their name and medical college? Absolutely not. The next thing is to know your target audience, because you need to know how many responses is good enough. Whether the survey is meant for general ophthalmologists or general and specialists or only specialists, that helps to you to know, so that you know what number is a good number of responses, so that you can end the survey and start analyzing. Accordingly, you can shape the invitations. And remember, if it's a survey meant for specialists, it's a good idea to first send it to only specialist groups or specialist mailing lists. And later on, you can come back and carpet bombing by sending it to all groups or all mailing lists. For example, this is a survey where we're looking at the lockdown on patient care. So obviously now we know this is meant for all ophthalmologists. The second is this survey that we conducted, which is looking at the impact of COVID-19 on training programs. So here we know we're looking only at residents. And finally, this is a survey where we are looking at practice patterns of lacrimal and eyelid disorders. Clearly, this is for oculoplastic surgeons only. So accordingly, we know what's a good number. And thereby, we were able to publish this, that when we reached an adequate number of respondents based on the kind of topic and the specialist that we were targeting. Finally, literature review. Now, I know this should have been probably higher up because a literature review is the first thing you need to do when the idea of a survey comes to your mind, so that you know whether it's a good idea. Has it been done recently in some different geographical area? What questions did they ask? Can I ask them again and, to get more information about something specific to India? How many respondents did they get so that I can compare it and know how many I should get? When did they conduct that survey? See, if they conducted a similar survey on, say, trends of intravitreal injections in 2020, I can do that now next month in 2025 and know what the change has been, because conducting the same survey at different points in time gives you comparative data, not just different regions, but also over different periods of time, and tells you how the trend is changing. So literature review is very important. The next thing is when you create your survey questions, it's good to add stratifying questions. And when I say stratification, you need to know age group, gender, your practice center, whether it's a government hospital, in private practice, or a group practice, or a corporate chain, number of years of experience, such as 0 to 5, 6 to 10, whether you're a resident or a practicing ophthalmologist. So it's important to get these stratifications so that you can actually make a meaningful comparison and say that, hey, it was found that those with experience of less than 10 years tended to prefer this route of management, whereas those with more than 10 years of experience preferred this particular management strategy. But at the same time, you don't want to complicate too many things by telling that, female ophthalmologists under the age of 30 practicing in private practice in tier 2 cities had this kind of preference. So that becomes too much. So this basic stratification is helpful. The next thing is uniformity versus ambiguity. It's important to know whether what kind of questions should you ask. Should you ask open-ended questions where you can have respondents type their answers versus multiple choice questions? I am clearly a big fan of multiple choice questions. Multiple choice questions are much easier. Wow, nice. In terms of the analysis, it's easier because now this was a survey that we had conducted where the question was, on an average, how many upper lid blepharoplasties do you perform in a year? I'm being very simple, very clear. And I'm also saying, please enter a number. But look at what the people have entered. 12 to 50, 10 to 12, 0 to 1, 4 to 5. Despite being as clear as you can, people would still give answers which are very difficult to analyze. Now, remember, this is a screenshot from an Excel sheet. Now, when you're looking to get an average of these will not compute because they are not numbers. They're not whole numbers. So you need to go in and change it. Now, remember, if you have about 200 or 300 or probably 500 responses, how many different variety of responses you're going to get. Same is the case when you're going to get people to type in their answers. Those answers and those questions are going to be extremely difficult to analyze and stratify. Rather, you should give simple blocks, 0 to 10, 11 to 20, and that's how you can analyze the data easier because multiple choices are simple, they are quick, and also see they are mutually exclusive. You do not want to make the mistake of 0 to 10, 10 to 20. Always make sure your options are mutually exclusive. It seems simple, but these are common mistakes that happen. Avoid long, complex sentences in your options as well. And make sure that all questions are compulsory for all respondents. That way, the total number of responses for every question is the same and the denominators are the same. Therefore, percentages are easier to calculate. If you think there's an option where multiple answers can be selected, always specify that select all options that apply for you. And finally, towards the end, work with the deadline. Think of sending out the survey invitation, keeping it open for 3 weeks or 4 weeks or shorter if you want. But if you want, you can extend it for a while. Always send out the survey to a close group of 4 or 5 people whom you trust, colleagues or people whom you're collaborating with, so that they can take the survey as a respondent and point out mistakes that you may not have. Remember, a second set of eyes is always better to go through and assess for any mistakes that may have slipped through the cracks. 90% of all responses are mobile. Always check for mobile screen compatibility before sending out these surveys. And at the end of it, send out an invitation, send a reminder at 2 weeks, and then you can carpet bomb on all groups saying, hey, please do it. You don't have to spam, send out too many invites of the same survey. So, make sure you send out well-spaced out invitations. I'll just go over a few mistakes that I have made. Not utilizing the Likert scale. Now, if I want to ask residents of how their training was or how is their surgical exposure, a question like, what do you think of your surgical training is not a good question. On the contrary, using the Likert scale where you ask the respondent to rate the answer from 1 to 5, 1 being poor and 5 being good, how adequate do you find the cataract surgical training during residency? This adds stratification, quantification, and standardized. And it's something that can be compared. All the websites like Google Forms, SurveyMonkey, Politics allow you to add this and also help you in analysis. Also, another thing is to avoid leading questions. You just need to ask, what is your opinion, rather than already putting in an idea of whether it is effective or not. How effective do you think is the new guidelines? No. Instead, what is your opinion of the new guidelines? And then you give options of effective, somewhat effective, not effective, and things like that. Also, if you've ended up asking a very exhaustive survey and gotten a lot of responses, it's good to divide them meaningfully. Now, we conducted a survey on lacrimal and eyelid disorders, and we had things, respondents giving answers on everything from congenital nasolacrimal lacrimal duct obstruction to DCR to a lot of other surgeries. So we stratified them into very meaningful projects. One was only on congenital nasolacrimal duct obstruction. One was only on adjuvants in DCR surgery like mitomycin C stents, and the other was NLDO and cataract. Also, when you're thinking of ideas of surveys, go beyond the usual. You don't need to stick to clinical topics. We've done a survey on work satisfaction, burnout, and inequalities that ophthalmologists in the field. And it came up with some surprising results that were published in the journal Work. We also, at the beginning of, I think, 2015 or sometime, when we were seeing a lot of people use their mobile phones for clinical photography, we conducted this survey to find out what do patients think about doctors using their mobile phones for photography, and came up with very, very interesting results. So to summarize, surveys are going to be meaningful projects only if they come up with meaningful results. So make sure you ask the right questions, and to do that, you have to do an exhaustive literature review first. Reach out to your colleagues, collaborate, and if possible, involve a professional body like your society, whether it could be a regional society, whether your city, your state, or a subspecialty society like VRSI. It adds credibility. And also, it always improves the collaborative effort. And finally, whatever you get from the survey, the data, always present the data at the appropriate forum and complete the manuscript and publish. Thank you so much for your time.
Thank you, Dr. Akshay. Are you there?
Yes, I'm here.
That was an excellent talk. For those who don't know, he's one of the top 2% of the world scientists as per the recent study by Stanford. And his surveys have reached up to 250 citations already. Thank you so much, sir. Do we have any questions? Okay, so I have a few questions. How much size is good enough? Like how many responses should we have? Especially given that we do not have any prior studies on that topic.
Yeah, so like I said, it depends on whom the survey is targeted at. If you're looking at a comprehensive ophthalmologist or pan-India ophthalmologist and looking at certain trends amongst all of them, then your target audience is 22,000 people at least. So there, even if you get anywhere between 10 to 12 or up to 15%, you're getting a good, sizable number of people responding there with 2,000, 3,000 people. So that would be enough. But if you're looking at a smaller society, like say, if you look at the Oculoplastics Association of India, we have 700 members. So in this subgroup, if you're looking at a reasonable amount of people to attend, to take the survey, surveys with 30% or more in terms of their response rate are usually considered good response rates. So that's what I would say. If it's a smaller group, you need to aim for at least a 30% if you know the total number of people whom you're sending it to. And most journals tend to use that as a benchmark, at least in our experience. Anywhere less than 30%, that's oftentimes we get back saying that the response rate is really not enough or representative of the entire group as a whole.
Thank you, sir. We have one more question for you, sir, from Dr. Mausmi Banerjee. Should survey questions be framed in a positive and affirmative manner or the other way around? So what's your take?
I think that's a very good question. I prefer to, just rather, and I mentioned, briefly alluded to it. It's a good idea to leave the question can be in a sentence form where you leave it neutral, as in, if you're looking at, say, for example, intracameral moxifloxacin reduces the rate of postoperative endophthalmitis. You can mention any statement and then how much do you agree with this, and then give a Likert scale of 1 to 5 where you go from strongly disagree to strongly agree. That becomes a neutral statement with which they can give their degree of agreement, and that can be used rather than giving it in a positive way or a negative way.
Thank you. Thank you, sir. Yeah.
Sir, I have a question, sir. So, can you tell the difference between a questionnaire and a survey, sir, and a little bit about their validation, sir?
Yeah, so I think that's a very good question. Validation of surveys, and so basically, whenever you talk, a survey per se does not need to be validated. Whereas if you're looking at a questionnaire, and say, for example, a quality of life questionnaire that you're creating for assessing a particular comorbidity or a particular condition, then you need to be able to validate and say that, yes, this questionnaire is truly assessing the degree of to which this condition affects the quality of life. So a questionnaire usually needs to be validated. Surveys usually don't need to be validated because you're just assessing practice trends or practice patterns and giving a point, the data at any one, like a cross-sectional data amongst a large group. And you're not giving anything predictive of, you're not giving any predictive trends. Whereas questionnaires tend to have predictive trends, which means that, say, if a person or a patient scores less than this percent on this questionnaire, the chances of them suffering from this severity of this disease is increases. So those kind of predictive trends, therefore, needs to be validated. So you need to have a pilot study, compare that with known trends, and then they say that, yes, our results get validated in terms of with real life data. We've conducted a pilot study, and therefore we have taken it into a larger audience. And this is the evidence that we are presenting.
Thank you, sir. Thank you.
Thank you, sir. We have another question similar to the one that Samir also asked. Do all surveys?
Yeah, I think I just saw that question. I think their answer covered a bit of that. So I think that, yeah.
Anything you don't want to add on piloting, sir? Piloting before they are sent across to participants. Yeah, I think you did cover that in your talk.
I did. I think piloting. So my talk is the talk that I gave was a very, very informal talk in terms of what I have learned from all the 17, 18 surveys that we published. Piloting helps really because sometimes you need to send it to a group of a small group to see their responses and to see if the answers that they give, is it adequate enough to be able to give you a significant difference where you're looking for it, to look for mistakes that you've made, and also in cases you've forgotten to include certain options that you did not think of. So that pilot group helps you in refining, polishing, and really sharpening the survey, the questions, and the order of questions.
Thank you, sir. Thank you once again, sir. If there are no more questions, Thank you, Akshay sir, for this extensive and elaborative inputs on how to start a survey. This is something that really helps us, and even we at a journal club team under Ayushi, we are trying to build up a survey for how we can improve the journal club sessions better. So I think this is a great learning for all of us and all the YOSI members who are also here. So thank you once again, sir. If there are no more doubts, I think I would like to call upon Dr. Pranesh to introduce the next speaker of the day.
Thank you, Prasanna. So for the next speaker,
Just a minute, Pranesh. I'm just putting the slide.
no issues. It is my greatest privilege to invite the next speaker, Dr. Surbhi Agarwal, consultant vitreoretina and cataract surgeon from Netradhamma, Bangalore. She's a alumni of AIMS with she being a gold medalist and also the Best Resident Doctor Award. She completed her prestigious Australian Fellowship in Cataract and Vitreoretinal Surgery and also is an assistant editor of IJO. She actively reviews for Indian and international medical journals and has contributed to over 20 published research articles. Notable achievements are inaugural diversity in retina travel grant at Las Vegas in the United States, awarded the Apple Tree Award at AOS for instrument innovation, and she is dedicated towards excellence in ophthalmology, patient care, and medical research. Thank you, ma'am. Thank you for your presence in this IGO Live. Over to you, ma'am.
Thank you very much for the very kind introduction. I'll just share my screen and get started. Is my screen visible?
Yes, ma'am.
It's gone out from mine. Let's see. Yeah. All right, so in this very august presence of RCTs and surveys, we are going to talk about letters to editors. What is their utility in the current research landscape? So after all the intense discussions, just a small light-hearted moment to show how the importance of letters to editor is perceived currently in front of original articles and meta-analysis. So letters of editors have for long been regarded the underdog of the publishing world. They are undervalued. They're stuck in this cycle of being undervalued and hence underused. So we're going to use today's talk to explore whether this image of underdogs that they're stuck with, whether we can get out of it and whether we should be getting out of it. So when I was asked to speak about letters to editors, I thought I would present my views on the topic, but then I thought it's a good idea to have a broader perspective of what the ophthalmic research community in general thinks about letters to editors. So I sent out this short survey to a few dozen mentors and researchers and teachers in ophthalmology to understand what their perspective of a letter to editor was. And I'm happy to say that majority of my respondents thought that letters to editor have a definite scientific value, and they do add to the value of the CV of a researcher, especially at fellowship, residency, and senior residency level. Since we are all young ophthalmologists here, I guess this is very, very relevant to us. Now, letters to editors can usually be of two types. Most commonly, these are responses to articles that have already been published in journals. Some journals also allow us to use letters to editors to raise new issues, report on methodologies or techniques or some current issues. But since usually LTs are responses to articles, we are going to stick to that discussion for the purpose of this talk. So usually these letters to editors are responses to articles that have already been published. They are very limited in terms of the word count and the time duration that you have to publish. Most journals will allow you anywhere between 4 to 12 weeks to send a letter of editor once the article has been published. So what does a response to this article contain? So it can be several things. So first of all, it can be a rebuttal or contradiction of what has been given in the article based on the writer's perspective and experience. To give an example, there was an article a couple of years ago in, I think, Ophthalmology Retina that talked about how dilated fundus examinations were not necessary while following up AMD patients. And we could just do an OCT at every visit and decide the retreatment of our anti-VEGF retreatment simply based on the OCT without doing dilated fundus examinations. I personally thought that that was not okay, because there are certain things we can detect only on fundus exams, like a fresh hemorrhage or maybe a peripheral tear, or maybe development of polyps that may be seen as oranges glow in the fundus. So that is something I did not agree with. So I ended up writing a letter based on my perspective and experience for that article. Responses to articles can also correct errors in the methodology, in the results section, in the analysis, or in the discussion. You can ask the authors to clarify certain things about the techniques they have used, or why a particular technique was used, why a particular statistical test was employed. You can also use in response to an article to corroborate the findings uh, of the manuscript. So if the published article contains topics that you agree with, then definitely go ahead and provide your published and unpublished data to corroborate that evidence. Basically, the response to article, the aim of this letter is to ask questions, encourage the authors to enhance clarity by maybe reanalyzing their results, relooking through their data, or clarifying some points that would benefit the scientific community at large. So basically what you're doing in an LTE is also looking at an article critically and raising questions. So what is the difference between a letter to editor and a peer review? Letter to editor is nothing but a peer review process. However, it is one that happens after the publication process. And actually it happens on a much larger scale. Before an article is published, it will go through a maximum of 4 to 6 reviewers and not more. However, once the article is published, it is actually available to the entire scientific community. Hundreds and thousands of people are actually reading that article and critically reviewing it. And in some ways, letters to editor have even more value than a peer review process. Why is that? Because one, everybody can do it. It is not by invitation only. It's not a handful of people being invited to do it. Letters to editor, unlike peer reviews, are not anonymous. Anybody who's raising a question about a study here is accountable for what they say, because their name is going to be signed in that letter. This letter is going to be published and it is going to be available for posterity for as long as the article is available. So in these ways, LTEs in some ways have way more impact than an actual peer review. In fact, LTEs are considered so important that the International Committee for Medical Journal Editors actually makes it mandatory for all journals to have this rebuttal or commentary process in the form of letters to editor or some other process. They also feel that critique and disagreement are a very important part of fostering a good scientific environment and actually furthering research. So this is a very interesting letter to editor which was published in ophthalmology long back. This is one which is very popular in ophthalmic circles and one that I would encourage everybody to read. We often think that letters of editors are the underdogs and they don't hold much weight in front of a original article. Now, this is a very well-written letter to editor by Dr. Mellis, who has actually pioneered quite a few techniques in lamellar keratoplasty. Very politely, yet very firmly, he has questioned the entire team of the journal, very reputed journal of ophthalmology, and called out another author who seemed to have published techniques as well as instruments which had already been published by him. A very interesting read, this one, and actually shook quite a blow to the original article for which this was published. So now we've already seen what is the impact of LTEs and how important these are. So are we utilizing this tool enough? If you search on PubMed, there are so many articles that have actually researched on letters to editors, and they tell us about how letters to editors are being used in the current scenario. So pat on the back, because there was this study that analyzed letters to editors across disciplines, maybe metallurgy, core sciences like physics, chemistry, organic chemistry, and clinical medicine. And they actually found that clinical medicine had the highest number of post-publication critique publications. Means clinical medicine actually publishes the highest number of letters to editor compared to other scientific disciplines. But here, this was another study which analyzed all the articles that have been published in clinical medicine over a certain time period. And they actually found that letters to editor have been published only for 5% of these articles. So that's a 95% gap right there, sitting right there for us to bridge. Now, we are all young ophthalmologists there. We've seen there is a gap there which we can bridge. How are these useful to us? So first of all, if you set out to write a letter to editor, this will teach you the art of critical appraisal. You'll actually be reading the article and analyzing it very critically, each section of the article, whether everything was done as per the requirements of the study, whether the analysis of the study was done accordingly, whether the conclusions reflect the actual data present in the results. So very good way to get started on the critical appraisal journey. It is also a very good way to learn how to review an article. And for young ophthalmologists, this can be a very good first step towards becoming a reviewer or even an editor for a journal. Letters to editors are considered relatively easy to publish. So it's a great start to a publishing career, writing a letter to editor with a mentor. And as we discussed before, these definitely add value to the CV of an individual. So which journals accept letters to editors? So that's the good part. You don't have to search for the right journal. All journals accept letters to editors for published articles. There are only a few journals which allow letters to editors to raise new issues. IJO is one of them, APJ is one of the other one. But letters to editors for published articles, every journal under the sun. A few points to make your letters to editor increase their acceptance rate and make them better. So usually these should be very brief. Very strict word limits exist for letters to editors. There is no general discussions should be done in letter to editor. They should be very brief, to the point. One to three major points should be covered. Avoid the temptation to point out minor errors in punctuation, grammar, technique, or whatever. Even though you're pointing out errors, the tone of the letter should be very professional. Use a neutral tone. When you're going to contradict what has been already published, and if you can find data to back that up and provide appropriate references, that will add credibility to your letter. And the last 2 points, I usually follow these for every piece of publication that I send in. Sleep on it. Read it 2 days later. You'll feel like a reviewer for your own article, and that really helps to make it better before publication. Also helps with the grammar, everything. And then also consider getting a second opinion from a colleague. There are some special considerations for letters to editors which do not apply to other articles which are published in scientific journals. So usually these responses to articles, they are not peer reviewed. And since they have to be published quickly after the original article was published, these are usually very, very sensitive to deadlines. Always remember that the aim of a letter to editor is to foster scientific growth. It is not simply to point out mistakes. So your criticism should always lead to enhanced discussions or enhanced patient care. It should have a positive impact always. To summarize, letters to editors, they encourage discussion, they encourage accountability of the authors who are publishing the study. They teach you the process of critical review, they add to your CV. The cons of letters to editors are that if you're going to apply for a government post or a promotion, these do not count as research articles for that. In my survey, when I was speaking to several senior ophthalmologists, they also felt that letters to editors are way less than a case report when counting the importance of a publication. Also, some people feel that letters to editor carry a slight negative undertone. So one should not have too many letters to editors on their CV. It means that you're, instead of creating original research, you're merely criticizing other people's work. So be careful of the amount or number of letters to editors you publish. It should be a healthy number, not an unhealthy number. Letters to editors are also sometimes perceived as a low-hanging fruit and easy publication. So you should be, again, careful about the number of letters to editors you have on your CV. Having said all this, letters to editors are a great way to actually further research, make authors responsible for their publications. They encourage debate. And when we are ourselves publishing an article and we know that somebody can tomorrow write a letter to editor and question everything that we've published, it makes us more accountable for our research. It makes sure that we are doing the right kind of studies, doing the right kind of analysis, and only publishing articles of the highest scientific value. So that's all. Thank you so much. Feel free to reach out for questions.
Thank you, ma'am, for your wonderful insights. We have a few questions. Firstly, I had one question that sometimes letter to editors are not just a commentary to other articles, but sometimes we do present our own original work, like it can be a case report or two cases or even original study or maybe a surgical technique. So how do you decide that where to fit it in? Like, would your case report be eligible for a case report or would it be a letter to editor? Like, how do you decide?
So usually I would go by the kind of articles that journal allows you to publish, wherein the kind of submission that you're submitting, wherein it is covered by another article type in the same journal, they will not usually accept it as a letter to editor. Only if your content is something that's not already covered by a separate head in the journal under consideration. Case reports would usually never be published as letters to editors. So they would either be surgical techniques or maybe a collection of a few peculiar findings that you may have seen, or something absolutely out of the ordinary, or something that's a very hot topic of debate currently. Things like these, which are usually not fixed topics in journals. And the difference is also that these, when if you're submitting a new idea as a letter to editor, it may be subjected to peer review. Usually this is always at the discretion of the editor-in-chief, and policies differ journal by journal. But usually this is letters to editors are under complete control of the editor-in-chief. A new idea might be submitted to a peer review, whereas the responses are usually not submitted to peer review, also in the interest of time, because they need to be published fast.
Thank you so much. Dr. Ashwin, do you have a question?
Yeah, we have a question from Dr. Satnik as well. A lot of the authors use letter to editors to boost up peer-reviewed publication numbers. I think you covered that in your presentation, but how does this pan out in India where numbers apparently matters a lot? So that's Dr. Satnik's question.
Yeah, so I did speak to a lot of senior surgeons and senior ophthalmologists also about this to get their thoughts about this, because they are the ones who are interviewing people and looking at publications and what matters. They did say that when they see a lot of letters to editors on a CV, it immediately gives the impression that this person has done it to boost up their numbers and does not give a very good impression of the candidate under consideration. So even if somebody is using letters to editors to boost up their numbers, as soon as somebody has an actual look at what those publications are, those that boosted up number is not going to matter anymore.
Yeah, and Dr. Ashwin is also asking a question on, is there a limitation to the number of letter to editors? Am I right, Dr. Ashwin? That's your question, right?
Not really. And my question is, in case you see an article and you want to write a letter to the editor, how long after the article is published can you still write a letter? Like, is there a time limit within which?
So usually differs journal to journal. You'll have to look at the policy of that journal. It ranges from 4 weeks to 6 months. Completely depends on the journal that you're publishing. And in my experience, I've also noticed that if your letter to editor raises a major point about the article under consideration, they may accept it a little bit later than what's been specified on the journal guidelines as well.
Thank you. Thank you.
Anujit, Niranjan, any of our panel have any questions or anything to add? Dr. Aishi?
I would just like to make two comments. Number one is that
Wanted to ask.
yeah,
Yeah,
Ayush.
Anujit, go ahead.
So regarding surveys and questionnaires, I've had cases where we've done questionnaire studies and they have not amounted to original articles, and there have been cases when we've submitted it to the journal, and following that the journal has replied back saying that it doesn't qualify for an original article. You can consider it as a letter to the editor, and in those cases, letter to the editor, sometimes the journal decides that this is worth a publication, but maybe not as the category which the authors are submitting in. So that's a nice criteria how letter to the editors get published. And usually when there is something new happening, for example, during COVID, there were a lot of letter to the editors regarding new techniques as well as examination techniques. And now with ChatGPT and AI in ophthalmology, there is another surge of letter to the editors going to every journal regarding Google Gemini and ChatGPT. That's what I'm seeing over there. So I think letter to the editor goes through a trough as well as a high-low sinusoidal curve. So now the sinusoidal curve is on a high. So those listening and are interested can take advantage of that.
But with caution.
But with caution, of course.
So any other questions from the audience to any one of the speakers?
I had a question for the panelists and speakers that
Yeah.
how are surveys ranked amongst the ophthalmology journals? Like I know that IJO publishes good surveys, but what are the other journals? Because not all journals publish surveys. If anyone knows about this.
Can you just repeat the question, Aishi? I just missed your question.
How are surveys ranked amongst ophthalmology journals? Like what are the journals that accept surveys? And do all journals accept them?
You see, one point that what Akshay Nair sir was telling, even I did a lot of surveys when I started my publication journey. And then Likert scale was one that I came to know very late. And then it really helped you in understanding the responses, at least standardizing the responses. So surveys do have a role, especially in journals like Indian Journal of Ophthalmology or even in European Journal of Ophthalmology. But there are certain journals which does not have those guidelines on surveys. So it depends on journal to journal, but good PubMed index journals such as our own parent journal like IJO surveys has a good role, as Akshay sir also beautifully pointed out in his survey. And maybe Dr. Surbi, ma'am, you are working in as an assistant or an associate in IJO. Your take on the same regarding surveys and getting those published in certain journals.
I really think it's not about a survey, it's about the real impact and translation of what your survey changes or whether how what if it's pointing to a lacuna, a practice pattern, how impactful that is on the general ophthalmology committee. So I have seen surveys being published in top ophthalmology journals also, but really depends on the sample size, whether you've actually captured a significant chunk of the audience and the lacuna at which you're trying to point out. Like, for example, a survey capturing resident cataract training in India may not get published in ophthalmology, but a similar one doing it in a country where the journal actually belongs to may get much more weightage there. So really translates into how much the journal, how important the survey is to the region and the editors of that journal.
So thank you. Thank you to all the speakers, as well as if we have no more questions. So the YOSI Journal Club team, we have this unique feature of giving e-certificates for all the participants, our hot seat participants, as well as the speakers and the chief guest as well. So I would request all of you to switch on your camera, and we would definitely like to acknowledge your presence, your time. It's unfortunate that Vanati ma'am was not able to join us today. But ma'am has helped us in devising this whole scientific program along with Dr. Ayushi here, who was another brain behind the three topics. So thank you, ma'am. Due to inevitable reasons, ma'am was not able to join with us today. But this is the sixth capsule, and ma'am has been very supportive of this IJO-YOSI live wire, where we have unearthed very candid discussions from day one. And also thanks to Dr. Sagnik, our very own UC member and our ex-executive, for your dynamic inputs, Dr. Sagnik, on RCTs. Thank you, Dr. Sagnik, for taking your time. As you are practicing abroad, we know how busy you are, as well as Dr. Akshay Nair, sir. Again, sir recorded his talk because he had to be at another place, but he was also there for discussion. Thank you, Akshay sir, for being very supportive of all the YOSI activities once again. And last but not the least, we had our Dr. Surbi Agarwal ma'am. Thank you, ma'am, for your valuable inputs. You are on the board of IJO, and for very pertinent and very practical point of tips, which will help a young ophthalmologist going forward. With that, I would like to thank our hot seat participants for making this session very, captivating and in a very interview kind of a way, or in a very discursive format. Dr. Akshay Chaudhary. I would also request you all to switch on your cameras, my dear hot seat participants, We have Dr. Ashwin PR again, who was very active in the discussion part. Thank you, Dr. Ashwin. We have Dr. Gaurav Lalla. Thank you, Dr. Gaurav, for being again with us today. Dr. Kaveri Birla. So thank you once again, doctors. We had Dr. Mozum Parviz. Again, he was also very active in the discussions in the chat box. Dr. Mausmi Banerjee, Dr. Neha, Dr. Rakshit Agrawal, Dr. Sameer Chaudhary, again one of our executives of IJO-YOSI, Dr. Samhita, Dr. Shalin Shah, Dr. Shilpa, and coming back to our conveners, Dr. Niranjan, again one of the core members of Journal Club team, and Anujit, who has been one of the brainchilds for the last 2 years for the Journal Club, be it the subspecialty and the IJO live wire, along with a few new additions, Dr. Pranesh Ravi and Dr. Arshi Singh, for also co-convening the session, along with Ayushi Agarwal. A big thanks to Dr. Ayushi again for coming up with this 3 topics, which was much needed for our young ophthalmologist. And last but not least, I am taking care of the Journal Club team. So if you have any suggestions that you would want to, the members watching it, if you want to participate or you want to post your suggestions, you definitely can get us at yosi.journalclub@gmail.com. We are all ears, and we would like to hear your feedback and refine the further sessions accordingly. So I just hand over to Ayushi also for your closing comments, Ayushi, before we thank few more people.
Thank you, sir. You thanked everyone, but I want to thank you for being a great leader and a team player. And I think I need 1 more hour to tell everyone your contributions in our life. Thank you so much, and I want to thank each speaker. Everyone had their own commitments and are busy, but you all still made it. And lastly, the Numerotech team for the flawless execution, and all the team members for this great session. Thank you so much.
And the flyer that you all saw, our co-member Dr. Niranjan is getting very busy with flyer designing. So thank you, Niranjan. Numerotech team.
Thank you, Prasanna sir. I mean, starting from the designing to overlooking it, you always were there to help us and give your feedback. Thanks a lot.
Yeah, with that, we'll have a quick photograph, our IJO-YOSI. Manjula ma'am, we can go off live as we are winding up with our photographs. So I request